So, thank you very much, everyone. It's wonderful, this meeting, because there are so many people that we catch up with around the country, but we're going to try and keep on time. So, we're about to start the second session, which is about the ongoing challenge of sudden cardiac death. As you know, it is still a major problem, so many lessons to learn. It's difficult to follow that first session. I thought the speakers were absolutely fantastic, but I think we can follow it. So, Rachel, over to you.
So, hi everyone, I'm Rachel Myles from Glasgow, and I'm glad to see the news that is warmer at the back has got round, so everybody's up the top. We're going to stay awake and sharp down at the bottom here because it's nice and chilly. So I'm really, really delighted to introduce my friend and colleague, Dr. Rachel Bekke from Maastricht University Medical Centre. Rachel's an assistant professor in clinical translational electrophysiology, and she has a subspecialist interest in genetic cardiology. Rachel's going to tell us about her fantastic and exciting work into electromechanical window in long QT syndrome. Thanks very much, Rachel.
Thank you, Rachel. Thank you for the organizing committee to ask me to come back to Glasgow. I'm very honored to be here and present you part of my work. An abundance of literature describes the physiological and pathophysiological determinants of heart action, focusing mainly on cardiac excitation and contraction coupling. Electrical activation of the ventricle produces mechanical contraction in the feed-forward loop. But reversely, it's also well known, especially in preclinical work, that mechanical contraction can contribute to electrical abnormalities. And now it doesn't move forward. Okay. No, it doesn't seem to work. Where did you look?
Just this one here.
Yeah, I did that.
Did that work?
Yeah, no.
Try again.
Yeah, now it's there. Thanks. Thank you. So the mutual influencing of excitation, contraction, and mechanoelectrical coupling in the beating heart, we designated the electromechanical reciprocity. And you can look at cardiac internal mechanoelectrical triggers and external triggers. Now, for the first, it is very well recognized that several interventions, like you've seen here, like releasing of bypass surgery or pulmonary valvuloplasty and transic aortic occlusion, can have an effect via altered volume or pressure loading on the electrical signature. For instance, it can affect the action potential duration, it can evoke early after depolarization, even trigger abnormal activity. On the other hand, externally triggers that are critically timed on the end of the T wave is able to induce ventricular fibrillation. Very well-known example is commotional cordis, which can be a deadly event during sports activity. So now to get back to the long QT syndrome, which you probably all know as a primary electrical disease, but I hope to convince you that there was also mechanical abnormalities underlying this disease entity. So it's already back in 1991 that the group of NADO had all found in M-mode imaging that there's abnormal contraction patterns in patients with long QT syndrome. So what they found was increased early thickening phase of the ventricle and a delayed prolonged contraction phase, as you see in the lower left side. And if you go back to literature in 1957, the seminal paper by Javel and Lange-Nielsen, you already can anticipate a simultaneous recording of ECG and a phonocardiogram looking at aortic valve closure, the S2, so that you can appreciate that the QT in this 9-year-old boy treated with quinidine, of all means, has a very prolonged QT interval. But the Q until the onset of aortic valve closure, which is like a surrogate for mechanical systole, was also prolonged, but not as much prolonged. So in this we have designated the electromechanical window, so the difference between the QT and the aortic valve closure. Usually in healthy subjects this has a positive correlation, so it should be the aortic valve should be closing after that the T wave has subsided. But in the long QT syndrome, it can be the opposite. And we have used this parameter evaluated this parameter in over 200 long QT syndrome patients, looking at risk stratification, just by simply looking at the continuous wave echo that you record in your everyday echocardiograms, looking at the aortic valve closure line and the corresponding T wave ending. And we found that in symptomatic patients, this electromechanical window negative is severely abnormal, especially in symptomatic individuals. It is a heart rate independent parameter that has an independent risk stratifier on top of the QTC. So this led to a net reclassification index of 13% of the patients. EMW negativity is stable in time usually. If you measure it on sequential occasions in the outpatient clinic, but when you have a patient that is electrically unstable, you can see marked changes. This was a coincidental echo recording that we made looking at EMW in a patient that was treated with isoproterenol for an electrical storm, an LQT type 2 patient. And whilst weaning of the isoproterenol, we were performing the echo, and she serendipitously developed torsade de pointe. And as you can observe, the EMW became markedly negative just in the final beats before torsade emerged. Now, how does this global electromechanical behavior relate to regional electrical and mechanical abnormalities? We all know, similar to the ECG, where you can look at T-wave abnormalities, you can also look at regional repolarization changes in ECGI imaging. And to the similar extent that you do with electrics, you can look at mechanical behavior. So this has been shown by the Christina Hauger group that the extent to which the left ventricular contraction duration in long QT syndrome prolongs differs per segment, especially in LQT2 type patients. And you can do the same thing with tissue phase mapping MRI, looking at mechanical and contraction and relaxation patterns. This was done in 9 pediatric patients, showing that there is severely depressed diastolic function and also prolonged contraction relaxation patterns in these patients. Now, how does this conspire to arrhythmia formation? For that, 3 hypotheses can be brought forward. And the first is, if you have a negative electromechanical window, this means that at the end of your contraction, the heart will be filled with blood and pressure will rise. And this will be done during an instance when repolarization is still ongoing. So this is nicely displayed in this PV loop in a canine model of LQT1. In red, you see the ST segment, and you see that there's a substantial filling of the myocardium of the heart during the ST segment. Now, this, we believe, pre-synthesizes the heart to additional electrical and mechanical impact, because what we often see in these canines when we give them isoproterenol is that they have secondary contraction, or as we term them, after contraction. And if you can observe in the right upper part, there is no the electrical activity preceding these after contractions. They mount up to 50 millimeters of mercury before torsade onset, and sometimes you can see them as a U wave on the electrogram. These after contractions, once they are suppressed by, for instance, verapamil, they prevent torsade from occurring. So they have a causal relationship with the arrhythmia formation. There are not many human data looking into this after contractions, but we did investigate one patient giving isoproterenol, so you can observe here that there is after contractions in the left ventricular pressure curve prior to the onset of PVC activity. And sometimes if you look back in literature, you wonder, very important papers showing these huge U waves, whether if they would have put an LV pressure catheter in the left ventricle, whether they would maybe have picked up some of these after contractions, but it's simply not looked into. A second mechanism of arrhythmia formation, of course, will be changes in short, long, short sequences, which we all know to potentiate repolarization abnormalities, but it can also evoke large pressure curves in the post-pause or beat. So again, having maybe some impact on the electrical signature. And the third reason may be the sympathetic hyperactivity, a well-known phenomena that induces torsade in clinical management of these patients. But this sympathetic hyperactivity also produces regional dispersion and repolarization, but also increased inotropy and chronotropy. So there's also a mechanical effect in that. Now finally, this is a very recent work that we've been working on, trying to really bring it all together. So can we pinpoint these after contractions and co-locate them with the site of ectropy in the beating human heart? It's of course very difficult. What we did is we looked in 6 Anderson-Tawil patients where we performed speckle tracking imaging and ECGI imaging to look at high-resolution electromechanical parameters. So this is the echo results. What we found is that, of course, they don't have a severely prolonged QT, but they do have a shorter contraction duration, leading to a negative electromechanical window. As you can see, it's minus 58, which is profoundly negative. But what strikes the eye is that there is a huge mechanical dispersion, so there is segmental differences in contraction and post-systolic shortening in these patients. Similarly, looking at high spatial resolution repolarization, you can really appreciate that there is large areas of high repolarization time gradients, so indicating pro-arrhythmic substrate, at least in this patient, very basally. And this was extremely so in patients with symptomatic events. Putting it together, there is marked electromechanical dysynchrony found in these subjects. And if you then look at PVC, of course we didn't have torsade in these cases, but usually many of these patients have PVCs. And if you look, most of them come from the basal aspect of the left ventricle. And what we then did is to investigate the mechanical behavior of these apical segments in orange compared to the apical segment where the PVC originated in blue. And what we observed was that there is a distinct different mechanical behavior of that specific segment that later produced the PVC. And this was in sinus rhythm, so there was no PVC at that point in time. So there's already a mechanical signature that is a premonition of the upcoming electrical stimulus. Now, putting it all together, and this is my pre-final slide, I hope I have convinced you that the Lonky-T syndrome is not an electrical disease only, but mechanics are also heavily distorted, not only at a global level, but also regionally. And I think it will be a paradigmatic disease for discovery of such mechanoelectrical and electromechanical reciprocities that will help us to further the field not only in inherited but also acquired cardiac diseases. And this is the team. We work in Maastricht, and with that I'd like to thank you for your attention.
Thank you very much. Very good. Okay, so I'd like to welcome to the stage Juan Kaski. Juan needs very little introduction. We know him very well for his work on pediatric HOCM, but he's also director of the Gosch Center for Inherited Cardiovascular Diseases, and so covers many other areas. But today he's going to talk about genomics to aid risk stratification in children. A difficult subject, Juan. So.
Yes, thank you very much, Jan. Thanks for the introduction, and thanks for the invitation. It's a real pleasure and honor to be here. So yes, as Jan says, my task is to talk to you about genomics to aid risk stratification in children. But I've added a little caveat to that, just in the interest of time, but also because this is, I think, where the most of the controversy lies, and I'm really going to focus on cardiomyopathies in children, so not ion channel disease. And just as a reminder, so these are the conditions that we're talking about when we talk about cardiomyopathy. So we have hypertrophic cardiomyopathy with left ventricular hypertrophy. There you go. With LVH, there's dilated cardiomyopathy we've heard about already this morning, left ventricular dilatation, impaired function, restrictive cardiomyopathy, and arrhythmogenic right ventricular cardiomyopathy. But as we've already heard this morning, these are not really diagnoses in their own right. This is just the start of a diagnostic process. It's the description of the initial phenotype that should then lead towards a more specific, more precise diagnosis. And in many cases, this will be a genetic diagnosis. And so genomics has a key role here to play. We've already heard about the interaction between gene and environment and about the possibility that in adults at least, a substantial proportion of cases of cardiomyopathy are likely to be polygenic in nature. But actually, when we're talking about pediatric cardiomyopathies, I think we really still are talking about primarily a group of monogenic disorders. And until really very recently, the role of genetic testing in the cardiomyopathies was really related to clinical screening. So we identify a pathogenic, likely pathogenic variant in an individual with a phenotypic diagnosis of cardiomyopathy that then allows us to offer cascade predictive genetic testing to relatives, and those that don't carry the variant can be discharged from clinical care. Those that carry the variant continue to be followed up. And to a certain extent, that still is probably the most important clinical value of genetic testing in the cardiomyopathies. But over the last few years, things have changed a little bit. And so we're beginning to understand now that genomics and genetics can have an important role, not just from a diagnostic perspective, but also, in some cases, prognostically, but also from a therapeutic point of view. So when we think about pediatric cardiomyopathies, we're talking about a really heterogeneous group of conditions. So these are just some of the examples of the conditions or the sorts of diagnoses that can be associated with dilated cardiomyopathy in children. Many of them are familial in genetics, others non-familial, particularly myocarditis, but we'll come back to myocarditis a little bit later on. We see something very similar in hypertrophic cardiomyopathy in children. All of these metabolic, syndromic, neuromuscular causes for left ventricular hypertrophy in the pediatric population. And these causes account for probably around 20 to 30% of all pediatric hypertrophic cardiomyopathy cases. And that's particularly so in infancy, so in the first year or two of life. That's where the etiology is most heterogeneous. Now, making a diagnosis of these rare diseases is really important because actually it can potentially guide treatment. We've heard about gene-directed management already in Brian's talk early on. And actually in pediatric cardiology, we've been doing this for years. So enzyme replacement therapy for Pompe disease, we know can cause regression of left ventricular hypertrophy in many patients. More recently, the use of MEK inhibitors, things like trametinib, is potentially a novel treatment for patients with Rasopathy syndrome, so Noonan syndrome-related disorders. So in a way, this is sort of gene-directed therapy in the pediatric population. It's not just therapy, though. We know that some of these diagnoses are associated with a particularly poor prognosis. So these are data from a UK national cohort that we published a few years ago now, but showing that a diagnosis in the first year of life is associated with a worse prognosis, and this is primarily driven by Rasopathies and metabolic cardiomyopathies in this population. This is in hypertrophic cardiomyopathy. And we looked a little bit further at this in a multi-center European study looking specifically at individuals who'd been diagnosed with hypertrophic cardiomyopathy in infancy. And again, we showed the same thing. So there's this significant attrition that happens in the first year or two of life, primarily driven by metabolic cardiomyopathies, mostly related to heart failure. So these are often patients with biventricular hypertrophy, severe biventricular outflow tract obstruction, often progressing to end stage to impaired systolic function. But importantly, still a proportion of these patients dying suddenly. And these are infant diagnoses. Similar sort of story in dilated cardiomyopathy. These are data from a North American cardiomyopathy registry, again showing a difference in prognosis depending on the underlying etiology. So clearly etiology and genetic diagnosis plays a role. But we know that the majority of patients with cardiomyopathies in the pediatric population actually don't have those rare diseases. They don't have metabolic disease or rosopathy syndromes. Most patients with cardiomyopathies presenting in childhood actually have the same sort of disease that we see in adults. So hypertrophic cardiomyopathy, primarily caused by sarcomeric protein gene variants in the pediatric population. This was a paper we published many, many years ago on a pre-adolescent group of patients. Over 50% have mutations in beta-myosin or C protein primarily. And we're seeing similar patterns emerging across other centers and across other cardiomyopathy subtypes. So these are data from the North American Pediatric Cardiomyopathy Registry, again showing a very high yield of genetic testing in pediatric cardiomyopathy patients. And the genes that we're talking about are essentially the same genes that are implicated in adults with the various phenotypes of cardiomyopathy. And very similar data emerging from our European Pediatric Cardiomyopathy Registry. So again, high yield of familial disease, high yield of genetic testing in this population. So if we focus on risk stratification, and when we're talking about risk stratification, what we're really talking about is risk stratification for sudden cardiac death in this context, although of course other outcomes are extremely important and perhaps even more important than sudden cardiac death in the longer term. But focusing on sudden cardiac death and focusing on hypertrophic cardiomyopathy to begin with, over the last few years there have been significant developments and advances in our ability to identify children with an increased risk of sudden cardiac death. So this was an international consortium that we established a few years ago, and we used this to develop the first pediatric-specific risk prediction model for hypertrophic cardiomyopathy. So this uses routinely collected clinical parameters, so things like left ventricular wall thickness, left atrial diameter, syncope, non-sustained VT, outflow tract gradient, etc. And we can use this to develop a model that predicts pretty accurately the risk of sudden cardiac death in children with hypertrophic cardiomyopathy at 5 years. And this model has now been externally validated independently in 2 very small studies from Sweden and from Poland, but also in a much larger study that we published last year, including centers that weren't involved in the original development of the model, including a large proportion of patients from the International Share Registry. So we have a model here that is pretty effective at predicting the risk of sudden cardiac death. But what about genetics? So this model does not include any genetic information. Again, for a long time, we've suspected that genetics has an important role to play in risk stratification in hypertrophic cardiomyopathy. In children in particular, many, many years ago, we suggested that those individuals with sarcomeric variants had a worse prognosis, a higher rate of sudden cardiac death and other outcomes than those without sarcomeric variants. More recently, the group of Seema Mittal in Toronto has published some data suggesting that perhaps patients with beta-myosin variants have a higher risk of sudden cardiac death. Certainly those with multiple variants, so 2 or more variants, compound heterozygotes or even homozygous patients have a slightly higher rate of arrhythmic events and sudden cardiac death. That de novo variants are probably associated with a higher risk of sudden cardiac death. And again, around the same time, data from the Florence group suggesting that perhaps patients with thin filament variants have a worse prognosis than those with mutations in other genes. About 6 months, a year after we published our model, Seema Mittal's group from Toronto published a very similar risk prediction model for pediatric hypertrophic cardiomyopathy that actually included pretty much the same clinical parameters that our model had, but they also tried to include genetics in some way in that model. And what they were able to show was that a pathogenic variant in any gene, so this is really pretty broad, but having a pathogenic variant in any gene was just about statistically significant as a potential risk factor. But actually, when they incorporated this into the clinical model, it didn't really improve the performance of the model at all. And this hasn't been published yet, but we also looked within our cohort to see how well that sort of genetic model proposed by the Toronto group performs. And what we actually find is that it really doesn't work at all. It overestimates risk quite significantly for most patients. And it certainly doesn't work as well as the clinical model or our own Hokum Risk Kids model. So why doesn't genetics work? Why doesn't including genetics or genomics in risk stratification models work? So I think one of the problems is that we're trying to look at this in a very broad level, so at the level of the whole gene. And that really is very, very broad. We know that there are lots of different types of mutations, lots of different genes are implicated in hypertrophic cardiomyopathy. Ideally, what we'd like to be able to do is to look at the individual variant level. So look at individual variants, but of course that's not feasible. There are far too many variants to look at, and in many cases these are sort of private variants that are only present in one or two families. Here's an example. These are just some of the variants that have been reported as pathogenic variants in beta-myosin associated with hypertrophic cardiomyopathy. But let me show you this family. So this is a boy here who's 13, or sorry, 11 at the time, asymptomatic, has this variant, which is a pathogenic variant in beta-myosin, very strong family history of hypertrophic cardiomyopathy, lots of individuals dying suddenly. There's a very significant phenotype, significant left ventricular hypertrophy, lots of late GAD on cardiac MRI. But what about these patients here, these relatives? There's this boy here who's affected with a phenotype, but these two siblings who carry the variant but don't yet have a phenotype. Can genetics, help us here? I might have missed a slide, there we go. So this particular variant that we're talking about in the family is a variant that exists within a particular region, the helix, the converter region of the beta-myosin protein. And we know that mutations or variants in this particular region are potentially associated with a much worse clinical prognosis. So in cases like this, it's possible that genetic testing might help us to refine our risk stratification. For me, though, the question is this really: can the genotype provide additional information to what we already have from a clinical point of view? And these are data that we're still working on, so this is very preliminary information. This is based on both our clinical cohort at Great Ormond Street, but also a genotyped cohort from Health in Code in Spain. And the first thing to point out, actually, so essentially what we have is our own sort of GOSH clinical cohort with our Hokum Risk Kids model, our prediction of risk, and then a prediction of risk that's based purely on the genotype, based on published data and available data in the genomic databases. And the first thing to point out is that there's really very poor correlation between our clinical risk score and the genetic risk. But actually, perhaps where genomics might play a role here is in identifying these patients here. So these patients who have a low clinical risk score, but where the genetics suggest that perhaps the risk of sudden cardiac death should be significantly higher. And it's possible that in that context, there may be some genotype-phenotype correlations that might emerge. Again, with beta-myosin, those are mutations in particular genes or regions of the gene that might be associated with a higher risk, that might help us to refine the model that we currently have. But as I say, this is still work in progress. That's hypertrophic cardiomyopathy, but what about the other cardiomyopathy subtypes in the pediatric population? So the reality, the truth, is that there are very, very limited data. So it was a paper that was published just a couple of months ago. This is probably the first attempt to use genetics in a prognostic capacity in pediatric dilated cardiomyopathy. This is a really heterogeneous group of patients. This is a Dutch cohort, but it includes patients with myocarditis, with neuromuscular disease, with metabolic disease. And the outcomes here are transplant-free survival. This is not sudden cardiac death, but potentially some interesting signals here. So those individuals with likely pathogenic or pathogenic variants, in any gene, seem to have a much worse prognosis than those in which a variant hasn't been identified. What I really want to highlight, though, is something that was sort of raised earlier on by Brian in his talk, and it's this issue of the MRI phenotype within a cohort of patients with dilated cardiomyopathy, and it's this identification of a particular scar pattern, this ring-like scar pattern. And the reason this matters is that the finding of that particular phenotype is potentially a red flag to think about specific genotypes that we know are associated with an increased risk of sudden cardiac death. So we're talking here about not just lamin, but vitamin C, as we've already heard, phospholamban, desmoplakin, RBM20, etc., where the annual sudden death rates that are reported are significantly higher than other causes of dilated cardiomyopathy. And it's these sort of groups of conditions that have been traditionally put under this umbrella of arrhythmogenic cardiomyopathies that includes, yes, ARVC, but also includes left ventricular disease, in some cases fulfilling conventional diagnostic criteria for dilated cardiomyopathy, but actually in many cases where the scar is the only thing that we see, or at least the earliest phenotype that we see. Now, all of this is based on data in the adult population. And if we shift the focus to pediatrics, where are we? So if we think about pediatric probands with arrhythmogenic cardiomyopathies, this is the sort of thing that we often think about. So 7-year-old heart failure, skin and hair manifestations with a homozygous plakoglobin mutation, so Naxos disease, very rare, but it's the sort of thing that people generally think about in the context of pediatric arrhythmogenic cardiomyopathies, or this case here, this family of 3 affected individuals with a dilated cardiomyopathy phenotype, malignant arrhythmias, and in this case, a Carvajal-like syndrome. So super rare, very, very high risk of sudden cardiac death. Alternatively, we think about probands who present with arrhythmia, so in this case, a 14-year-old with atrial flutter, ECG and imaging features that are very consistent with ARVC, classical ARVC, or another patient here, a 15-year-old with palpitation, presenting with exertional syncope and with evidence of sustained ventricular arrhythmias on exercise testing, for example. Very mildly dilated left ventricle and ring-like scar. We know that these patients who present in this way in the pediatric population have a higher risk of sudden cardiac death. There are limited data, but there are data to suggest that when we see this sort of pediatric presentation, it's often associated with a particularly severe phenotype. But what about the relatives? I think this is where really the issue lies. So at the moment, international guidelines suggest we don't screen below the age of 10 or 12 in arrhythmogenic cardiomyopathy. But I just want to finish off by showing you 2 or 3 cases from the clinic. So the first one, I think, actually, Brian, might be the girl in your family, because I've just sort of, this family history was very, very familiar. But this is a girl who's 6 years old, who presents for family screening because her dad has a diagnosis of dilated cardiomyopathy, and there's a family history of sudden cardiac death in his own father, without a known diagnosis. She has complex ventricular arrhythmias consistently and has left ventricular dilatation, impaired systolic function. And this is this sodium channel variant that actually responds very well to sodium channel blockers, as you say. So I'm sure this is the same family. Here's another patient. This is an 8-year-old girl, family history of classical ARVC, plakophilin 2 variant. No family history of sudden cardiac death, but there are some collapses and some ventricular arrhythmias. She has a pretty normal ECG for her age, at the age of 8. She has a normal cardiac MRI, normal echocardiogram. But on Holter monitoring, consistently has ventricular arrhythmias. And she's 8 years old. This is plakophilin 2. The final case, this is a 12-year-old, family history of cardiac arrest, resuscitated cardiac arrest in his father whilst playing football with a likely pathogenic RBM20 variant. Again, really very normal ECG for his age, very normal cardiac imaging, but ventricular tachycardia on Holter monitoring, and not once, but again, consistently. And there's now data emerging, this is from Christina Hauger's group, published only a couple of months ago, to suggest that certainly in classical ARVC, plakophilin disease, there is early disease onset if you look for it, and often this is associated with a worse clinical prognosis, a higher rate of sudden cardiac death. So these are very small numbers, these are anecdotal cases, but I think for me, this is where genomics probably has the biggest role to play in pediatric cardiomyopathies in terms of risk stratification. It's in that group of arrhythmogenic cardiomyopathies, that scar phenotype that we're only beginning to understand in the pediatric population. So the role of genetics, certainly in a very broad sense, thinking about metabolic, syndromic causes of cardiomyopathies, we know that they are often associated with a worse prognosis, and there are potential treatments that are disease-specific treatments for that, so important to identify those. There are potentially some genotype-phenotype correlations, probably more at the variant or region level than whole gene level. But I think the key question is, what additional value can genomics provide over and above what we get from clinical risk stratification? And I think, as I say, the arrhythmogenic cardiomyopathies, particularly the left ventricular forms of arrhythmogenic cardiomyopathy, are probably where this has the biggest role to play. So I'm going to stop there, but thank you very much.
Thank you so much, Dr. Kaski, for a fantastic talk. Next up, we have joining us from Amsterdam University Medical Center, Dr. Carol Ann Remme, and she is Associate Professor of Basic and Translational Electrophysiology. And really, Carol Ann is a role model for people like me who are interested in using basic electrophysiology to try and understand better treatments for our patients. So I'm really, really excited to hear Carol Ann talk about disease modifiers in channelopathies and implications for arrhythmia risk. Carol Ann.
Thank you very much for those kind words, Rachel, and thank you to you and also to Caroline for the kind invitation to be here on this wonderful day, but also very inspiring location, I have to say. So, in view of the time, I'm going to go a little bit quicker to the first slides, because I don't think I have to explain to this audience what we're talking about. We're talking about, of course, an inherited condition that is mostly observed in the younger population, especially also we talk about primary electrical diseases, channelopathies, and cardiomyopathies. So I'm going to focus on channelopathies, and of course we know that these ion channels are very relevant because they are the basis for the exponential, the basis for all electrical function in the heart, and we know that there are different ion channels that underlie the different components of the exponential, whether it's sodium channels for the upstroke, potassium channels, and calcium channels for the repolarization, and also, of course, ultimately with the goal of allowing for excitation-contraction coupling, right? I mean, that's the end goal. We need to have a good balance between these ion channels and ion currents to generate the ultimate calcium tensions to allow for contraction. Now, we know now for many, many years, decades of research, that there are many different types of ion channel disease, inherited arrhythmia syndromes, that are caused by many different genes or mutations in many different genes. As you can see here, of course, there's no time to go through all of them. For my talk, I'd like to focus on long QT syndrome, because I'd like to take you along on a little journey of things that we've observed in long QT syndrome. So, very briefly, long QT syndrome, of course, is associated with the QT interval prolongation on the ECG, and we know that there is a high risk of syncope, tachycardia, torsade de pointe, and of course, ultimately, potentially leading to sudden cardiac death. Now, when we think about the mechanism of long QT syndrome, there are actually two basic, let's say, general modes, if you like. We can have a decrease in the outward repolarizing potassium currents, which can either be due to mutations in KCNQ1 and KCNH2 genes, leading to long QT syndrome type 1 or 2. Conversely, we can also have actually mutations in SCN5A encoding the sodium channel, which then actually leads to an inward depolarizing current. Actually, the current doesn't, it's activated, but it doesn't inactivate properly. So we have a continuous influx of sodium throughout the entire exponential, and that can also lead to exponential prolongation. Now, why is this relevant? It's very relevant because we know now that depending on the genotype, so depending on the mutation that's involved and depending on the subtype, there is a very clear distinction between, on the one hand, the triggers for arrhythmias and sudden death, and second of all, how these patients can be best treated. So, for instance, we know from long QT1 syndrome, it's mostly happening during swimming and exertion, whereas in long QT2, typical triggers for sudden cardiac death and arrhythmias include auditory triggers and women in a postpartum period, whereas in the setting of long QT syndrome type 3, which is caused by mutation in sodium channels, it's mostly caused during sleep. So these patients actually don't wake up. And what you can see here also is that depending on the underlying mutation, we know that certain interventions can be more beneficial. So for instance, in long QT syndrome type 3, you could also think about late sodium current blockers, for instance, maxilitine. So if we think about what that genetic testing has brought the clinician, we know that it can help, of course, identify the patients at risk within the family, confirm the diagnosis, screen for family members, but also we can give these patients, specific, let's say, lifestyle advice, avoiding exercise, perhaps in long QT syndrome type 1, but on the other hand, also think about other preventive measurements. Now, the problem is, this sounds all very well. The problem is we also know that not everybody with the same mutation will be equally affected. And this is an example of a large Dutch pedigree consistent of about 164 mutation carriers of the SN5A 1795 insertion D. You can see here on the pedigree that only of those 164 patients, mutation carriers, 38 people had a sudden cardiac death or a life-threatening arrhythmia. The others didn't. And also, if we look at their ECGs, we see that mutation carriers can have completely normal QT intervals, or they can be significantly affected. Why is this? What's happening here? So apparently, we are not talking here about a disease that has a complete penetrance. Because if there would be a complete penetrance, everybody with this mutation would have the disease, would have QT prolongation, and would potentially also have arrhythmias. So we need something else, apparently. We have a reduced penetrance, so the mutation itself is not actually leading, it's not always making the disease threshold being reached. So we need something else that actually brings it up to the threshold. And what can those factors be? Well, they can be multiple. I'm going to skip this slide. So we need to think at it two ways. We can look at a clinical perspective and we can look at the channel, let's say the biophysical perspective. And this is a little bit of a complicated picture, but what I want to show here is that we have these ion channels sitting in the membrane. We know they have to get to the membrane, they have to be trafficked to the membrane. We know that there are certain conditions that can impact the trafficking. So fever, for instance, is a very well-known trigger for Brugada syndrome, for arrhythmias. And we know that fever can also impact the trafficking. But once these channels are on the membrane, there are many different factors that can also, affect their function, how these channels function on the membrane. And again, this can be, for instance, hormones. We know that females are much more susceptible to certain ion channelopathies, but it can also be QT prolonging drugs. And also, of course, there's a big role for the parasympathetic and the sympathetic nervous system. Excuse me. But if we look at a more clinical perspective, we can also say, well, what are these factors then? What are these factors in the clinical management of patients that can influence this disease severity? So again, I've mentioned gender. Age can be a very important factor. We know that in some cases, age can really make a difference in how the disease expressivity is concerning. And I'd like to draw your attention to these two here. So genetic modifiers, it has been discussed already in the previous talks. We know that it's very logical to assume that everybody has a mix of buildup of DNA. You don't just get the DNA mutation from your mother or father, but you get a mix of DNA variants from both of them. And we also, of course, it's very intuitive to think that can really influence your, your genetic makeup and how you respond to certain stressors, including a mutation. And the most clear proof of a role for genetic modifiers actually came from our work in the lab, we think, is where we took a mutation, we put it into a mouse, and then we bred the mutation on two different genetic backgrounds of mice. These mice are sitting in the same room, they're getting the same food, everything is the same. Their only difference is their genetic background. They have the same mutation, but the genetic background difference. And what happens is, the mouse on the right, this one, the nice brown one, actually is far more problematic, has a far more severe phenotype as compared to the mouse on the left. So there's a more severe phenotype of the iron current alterations, also of the QT prolongation that they develop. So clearly there's something, simply a genetic background can play a huge role. That's all very well, but how do we translate that to humans? And that's very, very tricky, because we know there's a lot of common variants that can modulate QT interval. So it's very intuitive to think that variations in that all these variants can ultimately determine how much QT prolongation you might get together with your long QT mutation. And so theoretically, this could allow to develop a genetic risk score. But it's very difficult to extrapolate these findings because there's a huge variability in patients. We would need hundreds, maybe thousands of patients to sort of, really find back those genetic risk scores. And also, it could very well be that depending on the mutation, the impact of other common variants may actually vary. So you cannot simply put all the long QT syndrome patients together. You probably have to do it maybe even subtype or mutation dependent. And that might actually also be different for gender, for instance. So there's a lot of work that would have to be, done to sort of figure that out. But the premise is there, but it will take a lot of work. So let's move on to comorbidities. It has been already alluded to in some of the earlier presentations, and I would just like to give you a very concrete example of what we've observed, again, in this pedigree, this large cohort of these mutation carriers. So again, these patients have the 1795 insertion D mutations associated with QT prolongation. I will show you that in a minute. And what you can see here is that people actually can suffer a sudden death or ventricular arrhythmias from the age of 13 up until 65 and so on. So over a whole range of age. So what's the phenotype of these patients? So these patients mostly have nocturnal sudden death, which we think is accompanied by this nocturnal bradycardia that then leads to a severe QT prolongation. So what has been the treatment for these patients? Initially is pacemaker. So the pacemaker treatment initially was shown to be quite efficient. So the idea was preventing the bradycardia, prevent the nocturnal sudden death. And that was actually happening quite nicely. However, in a more recent analysis of the family, we actually noticed that if you look at the red chart here, the red line, you see that people actually who did have a pacemaker suddenly were actually still dying suddenly. And I'll show you a little bit more in detail this graph. So what's happening here? If you look here, you see that before the age of 40, the red line is actually flat. So we have no people dying suddenly before the age of 40 of those who carry a pacemaker. After the age of 40, however, we still have people dying suddenly or having severe ventricular arrhythmias, despite having the pacemaker, which is counterintuitive because we thought we had solved the problem. So what was so special about these patients who had these arrhythmias after the age of 40? Well, this is probably a little bit too small to see, but as you can see here, all the red underlinings were actually, most of them had a clinical diagnosis of hypertension. And for some, we had echo data, and some we had postmortem data, and the vast majority of these actually had cardiac hypertrophy, possibly secondary to their hypertension. So again, this is a very, this is interesting, but how can we make it a causal relation? And to make a very long story short, in our mouse model, which I'm not going to go into detail, but what we did is we mimicked the hypertrophy in the mice carrying the same mutation. And when we did that, actually these mice were dying suddenly, similar to the patient. So there seems to definitely that even though wild-type mice were fine, the combination of the mutation and hypertension or hypertrophy was actually very detrimental. And I think that the clinical implication of this is that there could actually be two types of different arrhythmia mechanisms going on, depending on the age and depending also on the coexistence of comorbidities. So younger patients, actually, most of the sudden cardiac death was observed was due to the bradycardia and was actually cured, if you like, or prevented by the pacemaker. But at older age, we do get some hypertension, people get some hypertrophy, and then there's suddenly a whole different ballpark. And that also means that the therapeutic considerations, of course, are different. The pacemaker may not be simply enough. And so what's the underlying mechanism? Well, we know from our biophysical studies that ultimately this late sodium current, the sodium that comes into the cell and that's continuously coming into the cell, we get this huge intracellular sodium increase, and we know that that can ultimately also lead to calcium dysregulation. And calcium dysregulation can lead to hypertrophy, it can lead to diastolic dysfunction, and it can also lead to arrhythmias. So we think that the two together, of course, are like 1 + 1 is, 4 or 5. So they really can make each other and increase the propensity for arrhythmias. And maybe the hypertension in a non-carrier might not be so dramatic, but the combination with the cellular changes induced by the mutation can make it worse. And in addition to hypertension, we also believe, and again, this has already been mentioned before today, that diabetes and obesity can actually have a similar impact. Because we know that in the setting of diabetes and obesity, we have similar already changes happening in the cell. We have this late sodium current, we have calcium dysregulation, we have some inflammation, some cardiac fibrosis. So imagine if you do have some of this already happening, and you add on to that a mutation, and again, you have these similar things going on, those two together may really increase your propensity to arrhythmias. And I think that actually already with a smaller amount or a smaller severity of obesity or diabetes, it can already be a problem. And so overall, I think we need to start thinking about all these combinations of roles that we have. So we have electrical, structural, extracardiac, so hypertension, diabetes, obesity, and all of these together will ultimately lead or culminate into the disease phenotype in the patient. And that could actually explain why in certain cases you have this additional threshold, this additional link or an additional factor that will ultimately make the patient reach the threshold. And it kind of makes you think, do we need to sort of think a little bit more in patient management on, let's say, a diet, lifestyle, just taking a little bit more of a holistic view in all of this. And so with that, I'd like to conclude. Well, I think I've already spoken about this. I think it's very important to realize that there is a real, there's this variability in disease severity, and we can have genetic modifiers that impact on that. But most importantly, I think that the cardiac, the comorbidities will play an important role in this. And it's probably very important to keep monitoring these patients during follow-up and maybe a little bit more aggressively manage their comorbidities. With that, thank you very much for your attention.
Thank you very much. It was fascinating. So for the final talk in this session, I'd like to welcome Dr. Will Young. He is an SPR at the Barts Heart Centre. I've only just met Will. I was delighted to see you weren't the singer. So he's not going to leave right now. He's going to give us a talk on a fascinating patient.
I think the last thing you want to hear is me sing. Okay, great. So thank you so much for the opportunity to be able to present this case today. So I'm just going to dive straight in and present a background to the case. And actually the last talk leads up really nicely for this. So this is a 54-year-old female. She had a background of known long QT. She had a pathogenic KCNQ1 missense variant, and this variant sat within the C-loop domain, which is a variant which has been looked at quite extensively in the literature before in the past, and is associated, compared with other pathogenic variants, with increased risk of arrhythmia. And indeed, she had a single-chamber ICD implanted in 1995. She also had a couple of other diagnoses. Before the presentation that I'm going to talk about, she had presented 6 weeks before with gallstone pancreatitis, and that admission was complicated by multiple episodes of torsades and device therapy. And part of that was driven by being inadvertently given QT blowing medication and was also hypokalemic. She had a diagnosis of depression and was on citalopram for that up until that admission with gallstone pancreatitis. And she was also a smoker. So she presented to a local hospital with a 4-week history of exertional chest pain. It was cardiac sounding in nature, associated with breathlessness. She also described a 3-week history of night terrors and generalized anxiety. Examination was unremarkable, heart sounds normal, she didn't have any signs of heart failure. And her bloods were not hugely exciting either. She had a mildly raised CRP, a mildly raised troponin, a potassium of 3.8, but wasn't very exciting. But her ECG showed sinus rhythm with a rather long QT interval, more than 600 milliseconds. But she also had abnormal T waves in her precordial leads, biphasic in V1 to V3, which then led to T wave inversion in the lateral leads. And all of this was new compared with her previous ECG. Her baseline QT before in the past was around about 500. Enough to make anyone's heart rate go up in this room, I'm sure. She was started on danzatron, which you know does prolong the QT interval, in order to manage her nausea, and she was also started on pantoprazole. She was managed as an acute coronary syndrome because of cardiac sounding chest pain, T-wave morphology changes, mildly raised troponin, and a history of smoking. However, shortly after admission onto the ward, she went into electrical storm, and she had lots of device therapy, and this is just a snapshot from one of her device interrogations. You can see here a plot of beat-to-beat cycle lengths. Essentially, each time she was getting a ventricular ectopic R on T, to then get torsades, and that would rapidly degenerate into VF, and she'd receive therapy. She had an echocardiogram, and I appreciate this is off-axis, but hopefully you guys can also see that the basal segments are contracting pretty well, but her apical wall was akinetic. And she subsequently went on to have a CT coronary angiogram, and this was entirely normal. She had unobstructed coronaries. And it's paused. I wonder if I can get that back. Don't think I can. But the LV function was severely impaired, and this was new. A previous echo a couple of years ago was entirely normal. So I'm sure many of you in the audience have already guessed. She was given a diagnosis of Takotsubo cardiomyopathy, so new severe LV dysfunction, unobstructed coronaries. We brought her over to Bart's, she stopped QT priming medication, increased her potassium a little bit, started her on some heart failure medication and optimized her nadolol, but she continued to get some runs of torsades, so we upgraded her ICD to a dual chamber so that we could pace her right atrium 100% of the time in order to reduce QT dispersion and try and dampen down the automaticity that was driving her ventricular ectopy. However, importantly, and I guess the focus of my talk is actually she got another diagnosis during that admission. She continued to report night terrors and anxiety on the ward, and so our psychologist went to see her. She scored very highly on the impact of events score, which is a score used in order to help make a diagnosis of post-traumatic stress disorder. Fortunately, from an arrhythmia point of view, things settled down with atrial pacing, And when she was discharged, she had outpatient talking therapies, including counselling and CBT arranged. However, 6 months later, when I saw her again in clinic, we were presented with a bit of a dilemma. Her cardiac MRI done just before clinic showed that her LV function had entirely resolved. It was now back to normal, so fits with that diagnosis of Takotsubo. She'd also not had any further ventricular arrhythmia, which is fantastic, and she continued to be paced 100% of the time from her right atrium. However, she had ongoing severe psychological symptoms. She had insomnia, she was unable to sleep, she was concerned that she was going to get further shocks from her ICD. She was becoming increasingly restricted to her home as she was concerned about going out and receiving device therapy. And talking therapies, she found they didn't really help. And speaking with her psychologist, the general feeling was that she had complex PTSD. She'd had a previous diagnosis of depression. And actually, a next step, along with other psychological therapies, would be to add in some medical therapy. The difficulty is, where do we go with this? A lot of psychiatric medication, they prolong the QT interval. And she's clearly vulnerable to further arrhythmia. She's got a very nasty pathogenic variant. She's had a recent admission with electrical storm, having been given medication that prolonged the QT interval. And you might argue, well, you know, a lot of it maybe was driven before by the Takotsubo, which is known to prolong a QT interval, increase the risk of ventricular arrhythmia. But in clinic, her corrected QT interval remained fairly prolonged at 520 milliseconds. So we're a little bit stuck with what to do here. We didn't want to give her medication to manage her PTSD, prolong her QT interval further, and then result in, you know, her getting more shocks. We end up then in a vicious cycle, but she's clearly not coping at all at home. And so we explored options with the patient, understood what she wanted to do, and actually from her point of view, she was very focused on medical therapy for her psychiatric symptoms. She really didn't feel that talking therapies was enough by herself, and she was willing to accept a slightly increased risk with giving medication that might prolong her QT interval. And I guess from our point of view, she is atrially paced 100% of the time. That will help to fix the QT interval. She's got a device, so an ICD, so you know she can receive therapy if required as well. And so what we decided to do was to give her low-dose paroxetine, so 10 milligrams, which has a dose-response relationship with QT interval, not as big as with citalopram, for example. And we continue to just monitor her QT as an outpatient. Unfortunately, her QT's remained at 520, 530 milliseconds, and she's not had any further therapy. I think I'm running out of time, so just two last slides. The first being, we know that psychiatric symptoms are common in inherited cardiac conditions. And there's a higher prevalence of psychiatric disorders in long QT patients compared with controls. In small studies, patients with long QT and an ICD have a higher prevalence of PTSD. We also know that out-of-hospital cardiac arrest survivors have a higher prevalence of PTSD compared with the general population, and that represents quite a large proportion of our patients. But also, small studies have also shown that psychological distress also affects relatives as well. And this study looked at the parents of children who were given a diagnosis of long QT, and they scored very highly with psychological distress scores. But there's very little information actually out there, limited consistency across studies, and I think as we were discussing in the panel discussion with the last session, this is something really we need to look at nationally in order to try and look at psychiatric disorders in our patients. So in summary, I think this case highlights multifactorial contributors to a high arrhythmogenic state. It also really highlights the psychological impact of device therapy. And I think this case really benefited from working together between physical and mental health services in order to provide a holistic risk assessment and optimal management for the patient. Thank you very much.
So thank you very much. I'm going to ask all of our speakers, please, to come and form a panel. And I'm just slightly worrying that now I have to worry about mechanical function, comorbidities, and psychological status in my long QT patients. My life just got a lot more complicated. I'll have to think of something else to do. So would you like to raise your hands with any questions from the floor? There's one just in the middle here.
Any better? The patients you see who they've had predictive testing, they have clinical signs at a young age. Do you then complete diagnostic testing to look for biallelic or other PLP variants? Just thinking that if that had been the first proband, the index case in the family, they would have had a diagnostic panel. And it would cost, unfortunately.
No, thank you very much for that question. And so the answer is that we don't routinely do that anymore. But I think so the implication of your question is that if someone's presenting at such a young age with a phenotype, you wonder whether there's an additional sort of genetic variant that might explain that early phenotypic presentation in addition to the familial variant. And actually we have looked at that in the past, and the vast majority of the time we don't find anything else. So I really do think, and certainly for hypertrophic cardiomyopathy, which is what we have most experience in, I really do think that sort of early infantile presentation of sarcomeric disease is just sarcomeric disease presenting at a younger age. I don't think that there's an additional variant to explain that early presentation. In fact, what's interesting is that what we tend to see when we screen hypertrophic cardiomyopathy families is that when you see them at the very beginning, the first few months of life, those that are affected often have relatively mild left ventricular hypertrophy, usually about 8 millimeters. And then what tends to happen is as the heart grows, that doesn't change. And it looks as though it's resolving. So if you start to screen for the first time when they're 10, and they have a wall thickness of 8, you'll say they're normal. There's nothing there. But actually, they had LVH to begin with, and then during the teenage years, you see that evolving and developing. So I really do think that this sort of paradigm that sarcomeric disease doesn't present in young children, I think that's not the case. That there are, I'm talking about a cohort of patients here, and there are many other families in whom the phenotype really doesn't develop until later on. I think actually that happens in early adult years rather than during the teenage years. But definitely when we see early presentation in the context of familial disease, I think that really is sarcomeric disease presenting. And I think it's the same for the other cardiomyopathy phenotypes as well, actually.
Any other questions? So maybe while people are thinking about it, I can ask Rachel, your electromechanical window, do you have a sense from the studies that you've done, sorry, this monitor's in the way, what's driving those changes? Is it, do you think, to do with the long QT mutation, or is it something separate to do with the L-type calcium, or is it something outside electrophysiology? We've heard a lot about the interplay between what's going on mechanically and electrically. Do you have a sense of that from the studies you've done to try and help us understand what's driving those changes?
Well, if you look at it purely from the long QT syndrome perspective, you could imagine that if you have a intrinsically weak IKS current and sympathetic drivers are a higher tone, then you will have the situation that your repolarization will prolong more than it should. and lusitropic factors of the sympathetic nervous system will create then a negative EMW. On the other hand, there has been some reports in the 90s that beyond long QT syndrome patients with acute coronary syndrome may also have negative electromechanical window properties, and also recent reports on HCM patients actually also hint towards reversed electromechanical correlation in symptomatic cases. So probably it's a balance between repolarization and relaxation, and I don't know if there's any reports on calcium homeostasis in long-term genetic diseases that will impact on this. Probably there is something there, because I know Katja Odening has done some acute experiments in their rabbit model and chronic experiments, seeing that the acute effects of drug-induced long QT syndrome behave differently on the mechanical scale than prolonged chronic remodeling, probably. So probably there is some calcium dishandling underneath as well, but that needs to be clarified.
Okay. And Juan, do you see QT prolongation in HOCM children? I feel like we see some, and it's thinking about what Carol Ann talked about that really fascinating switch of arrhythmogenesis showing hypertrophy building into the arrhythmic risk in long QT. Is that something that you see?
Absolutely. So in fact, it's not unusual for us to see mild QT prolongation in patients with hypertrophic cardiomyopathy, which we've always assumed was just part of the muscle phenotype.
Yeah.
And actually, interestingly, it's particularly common in patients with Noonan syndrome. So in the resopathies, we really do see quite significant QT prolongation. We've looked for variants in KCNQ1, etc., and not found them. So I don't think that but of course we haven't found pathogenic variants. That's not to say there aren't sort of other variants that might be playing a role. But yes, we do see that. It's not uncommon.
Yeah, it's a really fascinating interaction. Carol Ann.
Yeah, sorry. So in relation to that, I was always wondering, if you get arrhythmias in the setting of a structural heart, that's it's intuitively explainable. I'm always wondering to what extent can these conditions, whether it's ACM or ACM, whatever, also lead to arrhythmias in the absence of clear structural abnormalities. So to what extent can all of this be pure electrical? And when you mention the QT prolongation, is that then in the absence of, let's say, echocardiographic abnormalities, or is it already a sign of remodeling, structural remodeling?
So that's a great question. So when we tend to see the QT prolongation, it's usually in patients who already have left ventricular hypertrophy. And at least, certainly in hypertrophic cardiomyopathy, it's extremely rare to see ventricular arrhythmias in individuals who don't have the left ventricular hypertrophy phenotype. It's not completely impossible. So we have families where patients have presented with out-of-hospital cardiac arrests without any obvious left ventricular hypertrophy in the context of troponin T variants, for example. But as a general rule in hypertrophic cardiomyopathy, it's really rare to see ventricular arrhythmias in the absence of LVH. For the sort of arrhythmogenic, in inverted commas, cardiomyopathies, I think that's a very different situation. But I think that probably, I suspect that you do still need to have structural heart disease. It's just that we're not very good at picking it up. But I think that sort of that scar phenotype, for example, is really important. So in the kids that we follow up in these families, with desmoplakin, for example, often the only phenotype that we see is a little bit of scar on cardiac MRI and ventricular ectopy on Holter monitoring. And certainly those patients can have ventricular arrhythmias in time.
So any other questions from the audience? I'm not going to let our abstract presenter get away without a question, so I'm going to ask Will. So it's really interesting. So I can think of a patient relatively recently where a long QT patient with exactly the same electrical storm, lots and lots of ICD shocks, and then developed a Takotsubo phenotype. From your review of the literature, which I obviously haven't done, so I'm just going to shortcut to ask you, do you think that is specific to long QT, or do you think it happens in anyone where there's electrical storm and lots of ICD shocks, or do you think we just don't know, is it not reported enough?
Do you mean any patient with Takotsubo, regardless of whether they've got diagnosis of long QT?
Yeah, so I guess our long QT patients, do you think there's any suggestion that they're more susceptible to developing Takotsubo after an ICD storm, or is it just not reported enough?
Yeah, so I think there's just not very much in the literature. So, funny enough, there were, I think, 3 or 4 case reports in 2009 of long QT patients with Takotsubo. So it definitely happens.
Happens, yeah.
But I don't think we know enough about kind of the prevalence within the general population.
No, it's an interesting one. And can I just ask also, did you think about cardiac denervation for that patient?
Yeah, exactly. So that was one of the things that we considered while she was an inpatient. But I think from her point of view, we presented the option. From her point of view, she actually wanted the kind of least invasive approach. I think she kind of reached a point where, you know, she wasn't very happy with having an ICD at all because it was causing so many issues, and then to undergo another procedure, she wasn't very keen on. But I think it's still a potential option in the future.
Sure.
How things go.
Great. Well, thank you all very much. I think oh, I'm sorry, please go on.
A small follow-up question to your case, which was a spectacular case. I really enjoyed it. But you also showed that the ECG during the Takotsubo showed marked T-wave alternance, if I saw correctly. So would you mind measuring the EMW for me? Tell me what you find.
Yeah, no, I'd be very happy to. Yeah, that was something which I meant to mention when I was showing the ECG. I'd be very happy to.
Thank you.
So there we go, we've got a collaborative panel, that's excellent. So thanks very much all of you for your attention. We're going to break for lunch now. I'm going to ask you to come back please at 1:45. Lunch is upstairs and the abstracts are going to be on display in the lower library where the exhibition also is. So please take a turn around there and see the abstracts that we have during the lunch break. Thanks very much everyone.